Echo VanderWal and her husband Harry lead the Luke Commission, an NGO delivering compassionate, comprehensive healthcare to underserved people in the Kingdom of Eswatini. After completing training as a mid-level provider graduating with distinction, Echo practiced in surgery. Following the birth of triplet sons in 2001, Echo joined a pediatric practice and ran a successful real estate development company. In 2004, after witnessing the devastation of untreated HIV, Harry and Echo moved to Eswatini and founded TLC. Ladies and gentlemen, it is a great privilege to have Echo VanderWal share her story at SAPEX 2024.
Good afternoon. I'm glad to be with you today and really excited to share with you our journey in Eswatini. As they said, we've been there since 2004, and over the last 20 years, we have ran into a lot of challenges, of course, in the healthcare environment, and our team has treated over 1.6 million people, and we've built some solutions that we would love to share with you today. We feel like these are solutions that could be helpful in all sectors. Our challenge when it came to healthcare is that 75% of our nation lived in rural populations, and we had the highest HIV prevalence rate in the world. Of course, there was a high cost of transport and unreliable supply chain, and of course, people were experiencing stigma at times in their healthcare facilities. We really felt that the best way to address a stigmatized disease, especially in the mid-2000s when things were very bad when it came to stigma, is through compassion and person-centered care. We built a fixed site hospital in the center of the country, and we run a mobile outreach network all over the country. We really believe that we should treat everyone like our father, mother, brother, sister, or child, and this has helped us to make difficult decisions over the years. As we mentioned, we were founded in 2005. My husband is an internal medicine and pediatrician, specializing in 2 specialties, and we served initially with a team of 8, working mostly in rural communities. As of 2023, we're a team of 700, 97% are local staff, and last year our team hosted 300,000 patient visits in our country of 1.3 million people. This is the Miracle Campus, which we bought in 2013. It was just a farm, a bare land, and since then our in-house construction team has built 25 buildings there, and it is the supply chain hub and referral center for all of the outreach teams. This is inside one of our operating theaters where we are doing specialized care. Our approach was to combine a culture of compassion with high-skill innovations, to build resilience into the team, which has been very important in the last few years, especially as we've undergone challenges, of course, around COVID, but also unprecedented civil unrest, and of late, really massive supply chain challenges in Eswatini. We've also worked to integrate the highest international standards for healthcare from around the world. Pictures of the team going out to one of the communities. The Miracle Campus is actually located right where that heart is, and you can see all the dots around the different places that we go in Eswatini. Pictures of the team leaving early in the morning. One of the ways that we've built trust with the communities is that we always arrive on time. So if our start time is 6, we're there at 6. If our start time is 7, we start at 7. And we really have found that people will engage in early prevention of disease and prevention of disease and early detection of disease if we keep our word to them. These are pictures of the teams deploying from the Miracle Campus, and they treat hundreds of people typically in the communities that they go to. All of those, since we're at a supply chain conference, all of those numbers on those tubs actually relate to a stock list in the system that we're going to talk about in a minute. And through reliable supply chain, we've been able to build strong relationships with communities in every chiefdom in Eswatini. So this is our challenge, one of our challenges that we're currently dealing with because of the supply chain challenges in the country where we have really terrible stockouts of drugs. Patients are coming in huge numbers because they know when they come they're going to find a reliable supply chain. So on one hand, it's a success. On the other hand, it's a challenge. What did we do? About 7 years ago, we started building a digital ecosystem, which we called Livello. We were experiencing, as you can see, exponential growth in patient volumes. We were managing about 45 different departments. We have all of our support teams in-house. So all of the teams, they also need to access whatever commodities they need. We have our own biomed supply chain, engineering. We really just run everything in-house, all of our support, including fleet maintenance and all of the buildings from woodworking, steelworks, plumbing, electrical are all just managed in-house. So there's a lot of commodities that are moving through and a lot of teams that need to be performing well. And so as that complexity increased, we looked for an off-the-shelf software solution and did not find one, largely driven by some of the challenges with low connectivity and bandwidth. And so we then decided to build a mobile-first enterprise software solution. We started actually, the first module that we built in the business operations side was for scheduling. But we are using a lot of integrations through facial recognition, photo verification, digital signatures, and other quality assurance checks that help us in the scaling process. So Luvelo, which means compassion in Eswatini, as I mentioned, is mobile first. I trained in the United States, but have lived for the last 20 years in Eswatini, and now a Leswati citizen. And in the United States, all of our digital systems, they were built for billing. And when I came to Africa, I found most of the work that we do in the digital space was built for grant reporting. But I've never seen a system that's built from the bedside of the patient. And that was our goal, because we felt if it was right for the patient, it would be right for reporting and right for billing. So we piloted Luvelo at the Luke Commission, and there were many things that we were trying to accomplish there, especially reliability around supply chain and personnel management, as well as the electronic healthcare record. So the mobile first, as we mentioned, we found that it really improved the training times as well as flexibility and adaptability from the staff. Users who were not used to using computers could easily pick up. As we know, handheld digital devices, we really don't do almost any work on laptops at all, and definitely no desktops in the system. So everything's being run through these digital handheld devices. We've also done a lot of work around the unstable or low bandwidth connections, really working to make sure our system maintains a 99.9% uptime, and it has offline modules whenever there are bandwidth or unstable connections to make sure that we can continue working. Transparency, of course, major piece of what we are trying to accomplish, especially because of the supply chain challenges that we face in Eswatini. Really wanted to optimize the tracking and full accountability of both staff and commodities by the use of various ways which really have helped the transparency within the system. It's interoperable, so they're stackable interlocking applications, and this allows there to be seamless workflow from department to department. And we also have a team that's on 24-hour customer support. We do have a fairly large ICU at the Miracle campus and have a lot of critical patients there, so it's really important this support that is given to the team so that they buy in fully to the digital applications. These are some of the different applications, which I'll talk about a little bit more in depth. We've also integrated a lot of innovations around vending machines, ATMs, badge printers, telehealth hubs, and drones. And we've used OutSystems, or low-code development platform, which has empowered us to train and capacitate local developers, and it allows us also to adapt rapidly to any changing environments. This is the HR module. We use clocking in through facial recognition. And here's just a short video, because we realize that if we have the right people at the right place at the right time, that solves about 80% of our problems. And if we have the right commodities, then we've almost programmed ourselves for success. So the transparency around clocking in has really helped us to become very efficient and have very little wastage in our HR system. We also have a conflict of interest that pops up every 3 months to make sure if we're working with anyone we know that is immediately logged into the system, which helps drive the metrics in the background. So if somebody's related to me, I will not be allowed to do their performance reviews, their contract renewals, or anything like that. It doesn't mean, because we're a very small country, we realize that we will work with people we know. If we say we won't, then we're not telling the truth, but we want to do it in a way that brings accountability. And probably one of the pieces of these applications that we've spent the most time on is the end-to-end supply chain accountability, because we recognize that at every one of the points from procurement all the way to end-user distribution, we are losing commodities in our systems, as I'm sure is true in the majority of the continent and throughout the world. But we really felt that we could build an end-to-end supply chain accountability system that would allow us to ensure that when patients or end users need commodities, they are always available. At the bottom, you can see it's also tracking all of our assets to ensure it's tracking all preventative maintenance. So every asset is tracked in the system, and the preventative maintenance plans, immediately when something is due for maintenance, it will send an alert to the appropriate department to make sure that we don't miss any of the maintenance intervals. And this is the supply chain module. As you can see, fully integrated. All of our doctors, all our personnel throughout the organization can see what we have in stock, because at times maybe we don't have one drug, but we have another drug that can be substituted. So we don't only want the staff to be transparent, we always also want the system to be transparent, so that we can ensure that as many lives that can be saved are saved, and no supply chain ends up hurting the patient in the long run. So everything then is asset tagged in the system, as you can see. Then on dispatch, it actually gets dispatched to the employee's bin. And this will track then whatever commodity or device or asset that the staff have in their custody. This has really helped us a lot. We are managing about 2,000 devices, electronic devices, and we really have the devices where they need to be when they need to be there. Also, at inpatient user, when they get their medications from the dispensary, the pharmacy, they take a picture, and this is actually captured in the electronic patient file, so that you can always refer to what the patient had dispatched to them. It also helps for follow-up. When we do follow-up with our patients, we want to make sure that we have a record of everything that was dispatched to them in case we made a mistake. But on the supply chain accountability side, I can tell you that one of the reasons our numbers have driven up like they have is because we do have commodities in stock. Patients know when they come. We will never send them to a pharmacy for their medications. It tracks everything, sensors in the fuel tanks and generators, in the water tanks and all our water systems. And it also manages all the maintenance for the oxygen plant that we built in 2021. I'll talk about that in just a minute, but this has really helped us. This is a short video around the maintenance application, which is applicable through all the different departments. In between wave 2 and wave 3, which I'll talk about in a minute, we actually built a very large 2,500 liter per minute oxygen production plant, PSA oxygen production plant. It was an investment of about 90 million rands, and so obviously tracking the maintenance on this investment is critically important. This is tracking then all the cylinders that are moving around the country, ensuring that, of course, we don't lose those cylinders. They're also very expensive, so making sure that all of these assets are where they need to be when they need to be there when the patient needs them. Tracking the purity of the plant, as well as all the digital monitoring for the plant. But what I love most about the system is it ensures strong patient feedback, which really helps us to make real-time course corrections so that if we have any gaps in our service provision, we can close them immediately. As soon as every patient leaves and they check out at the pharmacy or whatever service they've come for that day, they actually get a text message on their phone, and it just simply says, were you happy with your service? If so, press 1. If you weren't happy with your service, press 2. The minute you press 2, it creates a task in the task management system, which goes and is assigned to a senior manager who's on duty that day, because we know that from the scheduling system. and then that manager will immediately call. I call them patient whisperers. We get so much information back through these feedback loops to make sure that we close any gaps in our service provision, and these can be done in any language of choice. During COVID, our hospital took care of 90%, I'm not joking, 90% of the ICU cases in our country. How did we do that? I don't think we could have done it had we not had a development team that was actually in PPE beside us in the hospital, writing code literally as we were watching our time in motion, and 30 minutes later we would be using these apps that they wrote for us. One of the things that they did is they created a feedback loop where every time a vital set was not within the parameters that it needed to be in, it will immediately flag the doctors and nurses working on that unit, and it would only flag someone or send an alert to someone who was actually clocked into work and they could see was active in the system. So this assured alerts were not going to people who could not solve the problem. They also, through the asset tagging that you saw for all of our commodities, all of our medical equipment is also asset tagged, so as soon as a ventilator or monitor or any piece of equipment went on a patient, that went into the patient's bin, much like the employee bin. And this allowed us to keep track of where all the equipment was, because what we had happening at the height of COVID, we had 138 people admitted in our facility that were COVID positive, 91 in the ICU, and we had 55 ventilators running and 12 different types of ventilators. So some were good, some were not good. And so we wanted to make sure that we always were utilizing, of course, the best ventilators on the most critical patients, but when the ambulances would come in, we would have to make quick swaps. So they wrote these alerts for us so that we could see what ventilators were on standby, what ventilators were out for service, and where every ventilator was in the system so we could make quick switches. This is just the inpatient module, and we have outpatient module and surgical modules and like every other kind of electronic health module that you can imagine. I'm not going to go deep into this, but it's just amazing with picture storage. You can see that it stores actually the pictures of, say, wounds, so you can do wound tracking, and it's just made a massive difference in our ability to have much better outcomes. We also use the digital system, and we consult remotely with consultants all over the world. We have about 100 pro bono specialists that consult with us, and so when there's something that's outside of our scope or we feel that we need a second opinion on, just click the system, immediately sends a file to one of our consultants, and then we send images to them, as you can see here, and then they send us back their recommendations. This has really changed the ability to provide a tertiary or a very good subspecialty service to the nation. We're a very small nation of 1.3 million people, so you can imagine for the rest of our lives we'll be crying about not having enough subspecialists, or we can use digital technology to close the gap, and that's what we've done. I am not a technical person, I'm not going to go into this, but definitely the people that are working in the background, security is very high priority. Luvella was an MIT Solve finalist in 2023. We're an Africa Supply Chain Excellence Award finalist in 2024, and very grateful to be presenting here. Last year, just about a year ago, our King Mswati III, His Majesty King Mswati III, actually came and did an official opening, and interestingly enough, he actually toured for 2 hours and looked at the system. It was really, here he is like on one of the HR modules looking at the system, and he's inside the ICT department here, so it's really great to get the father of our nation to be able to see what is actually happening on the ground and what opportunities might be there for Eswatini and beyond. This is him opening the oxygen plant, which we'll talk about in just a moment. We've also used the digital system to really change the narrative in Eswatini around snake bites. As I know you have, and we have, the black mamba mostly for the neurotoxic side, and then on the cytotoxic side, we have necrosis, a lot of cases of necrosis from the puff adders in Mozambique and spitting cobras. But what was really sad is we were losing people all the time to black mamba bites, and we decided to partner with the Anti-Venom Foundation in Eswatini, and we actually have been able to change that narrative over the last several years. What we found is that there's shortage, of course, of supply of anti-venom, so supply chain accountability critically important. When this antivenom is going out into the other facilities, it was leaking out through the system and out the back door. So when people needed antivenom, you couldn't get it. Additionally, there were just challenges in the type of monitoring that you need to have. So we established a snakebite center of excellence and have really been able to make some good strides in snakebite treatment in Eswatini. These are just reports from the system showing the changes in admissions. We've admitted now about 400 patients since the 1st of September, which is the beginning of our snakebite season, and we're just getting ready to end on the 31st of August our snakebite season in Eswatini. And we're really, really excited because of the outcomes, which I'll talk about in a minute. This is mapping the different snakes and where the bites are occurring around the country. So these are all reports that we get on a daily basis or a weekly basis from the system, showing our stockouts. Even though there's been huge issues with shortage of antivenom, we have never stocked out in the past 7 years. And this is what we're most excited about, is that for the last 3 years, we have not had a death in Eswatini at our facility due to snake bites. It's really changed since we started using ventilators for the black mamba patients. But there were, 2 years ago, 25 patients that died on the way to the facility, having not reached us in time. Last year, we had 9 patients die on the way to the facility, not having reached the antivenom in time. This is one of the reasons that we put drones in the sky, because we were just tired of people dying from snake bites unnecessarily. But I'm really grateful to report to you that we have not lost one snakebite patient in Eswatini this year for the first time in recorded history. So if we make it 2 months, it's going to be a big milestone for the country. But I really feel that applying ventilators and the digital system so that we can get a real-time monitoring of all the symptom checks has really changed the narrative. This is a picture of a young girl who just came in, actually a 2-year-old child who came in just about 2 weeks ago into our facility from another facility. She was on a ventilator. This is another patient, a 9-year-old girl coming off the vent, going home to her mom. It has just completely changed how we address snake bites in the country. Now people know. It used to be that the doctors would just tell people, say your goodbyes if you get bitten by a black mamba. Now everyone knows if I move fast and get to the Miracle Campus, I'm going to get antivenom, and I'm going to live. And it has changed because now all of the referring facilities are also doing the same thing. So the patients are moving in much faster. I'll talk a little bit about COVID. This is our ICU during the 3rd wave of COVID. During the 2nd wave, it's very sad to say we as a country had absolutely zero local production of oxygen. In fact, we were completely dependent on South Africa for oxygen, and we only had about 400 cylinders of oxygen coming in to Eswatini every day from South Africa. And because the digital system is actually giving us data every single minute as to how much oxygen we're consuming, we knew that of those 400 cylinders, our facility alone needed 200 of them to sustain the lives of the people that were admitted. We all know the math doesn't work from a supply chain perspective. There's no way one facility can take half of a country's oxygen supply, and it didn't work. We had trucks coming all times of night and day. On the left-hand side here, this is 1 day of cylinders waiting to go back to South Africa to be filled, and we were running vents on those cylinders. It was a really difficult, really, really painful time. We lost a lot of people in Eswatini unnecessarily, and we really felt that if we wanted to do something different, we had to gain oxygen independence from any other country. In this case, it was South Africa, and it really changed the outcomes. As I mentioned, we admitted 90% of the nation's COVID ICU patients, as well as we constructed a 2,500 liter per minute oxygen production plant, which I've only learned since then is the largest of its type in the continent of Africa. At the time, we built to data. We were not experts at building an oxygen plant, but the real-time data in a crisis allowed us to make a good decision, and it really changed the outcomes then in the 3rd wave of COVID. We actually had 12 people in the night shift, 12 people on the day shift just moving oxygen cylinders. Our IT managers, this is all during the 2nd wave. Our ICT managers, all they did was manage regulators. We backfilled with technical teams from all the different departments to make sure that nurses and doctors were only doing what nurses and doctors did. But we knew if we didn't change something and build a plant, we would not have any different outcomes in the 3rd wave. On the left-hand side, this is a picture inside our ICU in the 3rd wave, and I'm going to share with you now. This is the data coming from the system showing how much oxygen we were consuming during the 2nd wave, and initially the size of plant we were going to build was 1,000 liters per minute, but when we were rationing, we were almost using 1,000 liters per minute. So we increased the size of the plant, as I mentioned, in real time to 2,500 liters per minute, and this is what happened. The first week of January 2021, our team with other technicians installed reticulation systems in all of our buildings, and then just 6 weeks later, we hooked up to a 20-ton liquid tank from South Africa as a bridge to us building the oxygen plant. Of course, there was a lot more oxygen in that than in any cylinder, about the equivalent of almost 2,000 large cylinders of oxygen, and we were able to deliver it through a centralized system. Then the team immediately flipped down after hooking up to the liquid oxygen tank to build the plant that you see here, and they built this plant, our on-site construction team, they built the plant in 52 days. They worked every holiday and every weekend in between the second and third wave. It was an absolute miracle to watch. The grit and resilience from the team, they never gave up. They saw what happened in the second wave without oxygen, and they were just absolutely determined to get this plant done before the third wave. And then on the 9th of June, just about 3 years ago, for the first time in Eswatini's history, we started producing oxygen in Eswatini, and it totally changed the outcome. These are pictures. This is on the cylinder filling side of the plant. We can fill 200 large cylinders of oxygen per day. Everything being tracked through the digital system, cylinders going out to other facilities, all being tracked and through the supply chain system that was built in Luvelo. So as I mentioned, the plant was finished in 52 days, and we started producing oxygen just 20 days before the third wave started. The third wave of COVID in Eswatini coincided with our unprecedented civil unrest, and they were burning fuel trucks that were coming in from South Africa, and so force majeure was enacted in all of the contracts for movement of hazardous materials, and including oxygen, during which we were then in the third wave. And this plant was the sole provider of oxygen for our country for 2 weeks post our civil unrest. It really changed things in the third wave. As I mentioned, we had 138 patients admitted at the height of COVID, 91 in the ICU, and 55 on ventilators, and our peak oxygen consumption exceeded the capacity of the plant. What did our engineering and technical teams do? They actually mixed the liquid oxygen with the PSA oxygen so that we never had to ration oxygen ever one time in the third wave. This is the story in data. On the red line, the amount of oxygen we consume if you don't include COVID patients. The blue line, the amount of oxygen we consume if you do include COVID patients. On the purple vertical line is the day that we paid the deposit to start building the oxygen plant in Eswatini. The yellow vertical line, the day we hooked up to the liquid oxygen tank from South Africa, and the green vertical line, the day we started producing oxygen in Eswatini for the first time. And then you can see on the blue peak what the nation demanded from that plant immediately on commissioning. This is outside of our hospital. We had to keep people in tents, in this tent, just while we decided what unit they were going to, because we were receiving ambulances from all over the country in rapid fire succession, like you can see in this short CCTV video clip. And this was what our team did for an entire 2 years while COVID was happening in Eswatini, because we were the go-to facility for the nation for COVID. This is inside our main ICU. There's 48 people on ventilators here, and now you can see everyone on the digital devices. I shudder to think the number of people we would have lost unnecessarily without the digital ecosystem that has really changed the way that we do business. And this is what happened. In the second wave, Eswatini had one of the highest case fatality rates of any country in the world at 4.4%, mostly driven due to the fact that we didn't have enough oxygen in the country. And then in the third wave, that dropped to 2%. We did receive a large number of ventilators from a philanthropist, actually Nati Kirsch from the Kirsch Foundation, as I think probably some of you from South Africa know him, and that really changed the outcomes as well. But we also then afterwards asked one of our donors, USAID, to please help us to install the liquid oxygen tank, because we learned that if we didn't have that redundancy, we would have still lost a lot of lives, even with the plant. So we're really grateful to be standing really on three legs: the PSA oxygen production plant, the liquid oxygen tank, and cylinder reserves. So our SOPs require all of the cylinders that are on site to be full at all times, because that's the third leg of the oxygen stool. But this plant has produced about 500 million liters of oxygen in the past 3 years. So the oxygen plant also consumes a lot of energy, so then we had to start installing solar. We're also a little bit worried because we are getting most of our power from South Africa, so our contract for Eswatini expires in 2025. We are on the fast track to get nearly off-grid by the end of this year to try to make sure we secure the infrastructure there so it can be utilized for patient care. We're also installing data loggers in many of the facilities around the country to gather data on the energy consumption and energy blips, which is the plan for that data is that it's going to inform future solar investments in the country. And we've also been working on some other innovations, which I'll just go through quickly. One of the things that I worked with my husband for the first 8 years in clinical care, and I was so sad that people would get on buses to go to the hospital, spend the whole day, and what meager resources they had, which could feed their children or could put their children, assist in their children going to school, but they were using this money to travel to hospitals so they could get things like Panados, oral rehydration salts, things that you and I all have in our homes. So we really wanted to decentralize that because we feel that telehealth is being used really well, especially in the first world, but is telehealth being used where telehealth is needed most? Not really, not yet. And so we really have been working for about the past 4 years to perfect a concept that we had to take these containers, which I'll show you in a minute, off-grid. First, you'll see in a minute the patients register, then they get their vitals checked, and then they do a virtual consultation with the doctors, and then their medication is dispensed via vending machine. This is just a conceptual plan. This is actually prototyped now at the Miracle campus. Here they're doing self-check-in. In the second bay, getting their vitals checked. In the third bay, consulting with a doctor, and then in the fourth bay, which you can't see much here because it's all inside the container, is where they use their once-off pin to actually get their medications. So this is all run off-grid we have gotten Starlink approved in Eswatini, so now we're able to use Starlink for the connectivity as well as solar for powering this solution. And then you can see kind of what's behind the scenes. Now she's taking her vitals, then she's consulting with the doctor, and then as soon as the doctor orders the medications, it sends her a once-off pin. And that once-off pin, then she will go to the vending machine, as you can see here, put in her patient ID as well as her once-off pin, and then it goes to fetch the medications. This vending machine system that we've been building for the last couple of years can actually hold 270 SKUs and up to 3,000 items. So it's really very much different than some of the smart lockers that have been utilized, which are good, but for a smaller number of patients. So we're really excited. We'll be putting 2 of these out in some of our more populated areas in the next couple of months. And then, as I mentioned, we have, for the last several years, been working on putting drones in the sky, and we've never had an approved drone network in Eswatini, so the Civil Aviation Authority didn't have the documents for that, so we've been working with them. They've really done an amazing job in bringing this on. In fact, on Friday is our official launch, although the drones are already in the sky. So one of the things, as I mentioned, was the snake bites, but other things that were bothering us is that women were dying after giving birth due to postpartum hemorrhage because there wasn't oxytocin available. In our environment in Eswatini, we need to have on-demand dispatch of high-value commodities because if we store those in all of the facilities around the country, they're just not there when you need them. Thankfully, we have a small enough country that we can reach the whole country within 45 minutes, and 75% of the country we can reach in 30 minutes. So we've been working on this for quite some time. I'll just take you through. This is our drone hangar. And the drone that we're using right now is the Kite from Swoop Aero, although we've developed this program to make sure that we can integrate other drones over time, but this is the one we're starting with, and it has a 3 to 4 kg payload. What we really wanted was the ability to have two-way transport of commodities and then lab samples back. Another big challenge is that we don't have enough blood in the country, so consolidating some of these hard-to-get medical commodities will definitely save lives. Another big goal of our program was to ensure that we build local capacity. We did not want to bring in a service provider, so that was a non-negotiable for this program. We're really excited that we've trained 5 drone pilots from Eswatini, and they are operating the network and have trained in South Africa, scored very high in their exams, so we're really, really excited about that. And that was very important for the Civil Aviation Authority. Not only did we not want service provider coming from outside the country, but neither did the Civil Aviation Authority. So this has been really, really amazing. They've really, the Civil Aviation Authority has taken our team under their wings and are really excited about what they see happening. So we know we're cutting a lot of time off of transport. These are our drone pilots and a trainer from Kenya there. And this is on site of our drone hangar at the moment. Because we're a small country, we have 4 aircraft. As more demand gets on this network, then we'll increase the number of aircraft. And this is our remote pilot station. One of the things that also, just for those of you involved in drones, really helped with our Civil Aviation Authority is that we installed a monitor in the control tower at the airport so that they can see at all times where the drones were moving. And that level of visibility really did help to build trust, and was really kind of a low-cost intervention that we were able to do.
Booting up. Please wait. Takeoff countdown commencing. Stand clear. Stand clear. Stand clear.
So we are not saying that this is something that works in every country, but for our country, pooling and having a hub with high supply chain accountability for high value commodities and things that are difficult to get, like blood units, has really made a difference in the country. One of the reasons we are excited to be here is because we're confident that some of the solutions that we've developed over the last 20 years can not just solve problems for us, but can solve problems for people like you. It's been interesting because we're kind of a quiet team that's just low to the ground, always working on what's next best for the patient. We're actually really poor fundraisers. That is not one of our strengths, but we are hard workers on the ground. But what has happened since COVID is people are coming from all over the world. They want to see 2 things, the digital system and the oxygen plant. And we've received visits almost every week from every continent except Antarctica. And what's interesting is once they tour and they see the digital system and the oxygen plant, which are pretty remarkable in and of themselves, what they're most excited about is the resilience, grit, and just amazing teamwork that's happening with this team of 700 in Eswatini. So I always say that, all the resources in the world do nothing if you don't have people willing to do the hard work. I've got several of them sitting here today, so we're really excited about just what they've been able to show the world because of their dedication to patients. These are some of the things that people are saying. Our PS of Home Affairs, I would like you to share the technologies and innovations so we can move to Vision 2022. It's a vision of our King, His Majesty Mswati III, to be a first world country. We had a vision by the year 2022. We were hoping that we opened to Zoom to that. Didn't quite make it, but I'm looking forward to being able to make some strides in that in the near future. TLC has dropped down to Eswatini from heaven. We don't need to take a plane to the US or UK. You are all here. The benchmarking we need to do in our own for Eswatini is here in our own country. World Bank Country Director for South Africa, Botswana, Namibia, Lesotho, and Eswatini. This is the quintessence of excellence, innovation, and impact in health services. How can we scale this in the kingdom and beyond? Johnson & Johnson came because we built a digital system for our government for tracking all the COVID-19 vaccinations, and we actually had one of the highest vaccine utilization rates in the world because of the accountability of the system. They came because they were working on the injectable ARVs to see that system. I've never seen anything like this anywhere. I'm going back personally in awe of all of you've done and accomplished in Eswatini. You're leading the pack, and what you are doing should be done elsewhere in the continent and beyond. Senior Supply Chain Advisor from Global Fund in Geneva. We've been looking all over the world for he said it like that, the global oxygen solution since 2019. And then he said, we found it on the Miracle Campus. The next thing he said, and where's our logo? Because unfortunately, when our nation reported to Global Fund, they did not include this massive plant in what they reported to Global Fund. So there was a bit of equaling of that story that had been told, that's what he was responding to, but really great to have them be able to come and see the plant. And then we've recently started a joint replacement program because in public health there's no one doing joint replacements. And we're actually using an implant from Australia, and it's a very high quality implant. But one of the surgeons that came, and this always shocks me when people come from Europe or the United States or Australia, other places like that. This is what he said. He's actually performed 12,000 joint replacements in his life, and he said, TLC is an amazing place, mostly because of all the people here, the people on every level that you interact with. They lead with compassion, and it's not just something that's on their shirts. They truly lead with compassion. I've never been at a healthcare facility that has operated with this level of efficiency and just doing things right. There are things that are done here so well that I've never seen happen in any healthcare facility or in any facility in any industry in any country in the world. I'm going back to, and he blew my socks off with this, and I'm going back to the CEO and telling him that Luvello is better than the EHR we have at Texas Orthopedic Hospital. And then this one changed my life. This was about 2 years ago. There was a senior political advisor from DC who actually worked next to Joyce Banda during the economic recovery in Rwanda. And he toured, they gave me intel, they said he's gonna be real tough. He's a tough one, so don't be thrown off when he comes. He wasn't tough, but he did say something that changed me. He said, the digital system that you have built can change the GDP of nations. And then I realized that there's something that we need to share with the world, that we shouldn't just be keeping it in our small little pocket in Eswatini. And then the second thing he said was TLC's commitment to and systems for organizational excellence will save more lives than TLC's work in healthcare. That was also really shocking to me because we had spent 20 years very deeply involved in healthcare, so recognizing that maybe some of the other systems will be valuable to the world really started to change us as an organization, and we really are appreciative to SAPEX for giving us the opportunity to come and share our experience in Eswatini. Thanks a lot. Thanks for allowing me to speak. We're at booth EB16, and we'd love to see you. And our people up here that are making sure I say the right things, like, no, we'd love to see you. I'd love to have you come to Eswatini. It's close, so feel free to come and do your own tour of the campus. We'd love to have you there. Thanks a lot.